De la Garza, Dr. Tracy, Dr. Dalton, and others. I'm going to give an update on complex regional pain syndrome. Many of us in the audience, I think, have some familiarity with that condition. Show of hands, how many people treat CRPS on a regular basis? Okay. Does this advance my slides, Deborah? I think so. So I don't have any disclosures as they relate to this educational activity, but I will caution you that we're going to go through an awful lot of material in the next 20 minutes. And it's about 70 slides, so I'm going to speak not too quickly, but I'm going to try to give you the salient points about the misunderstanding of CRPS, as well as what the evidence is in favor of the modalities that we have to offer our patients suffering from this condition. These are my disclosures. I've published about 200 scientific papers. I've written 100 textbook chapters. I've given 1,000 CME lectures. The objectives today are to obtain an understanding of the current state of what CRPS is, the history of interventional therapies, what works, what doesn't work, why we do what we do, because oftentimes we apply therapies that have no scientific evidence in their favor. For example, sympathetic blocks don't have level 1, level 2, or even level 3 evidence in favor for their use. Ketamine, that many of us use, does not have level 1 or level 2 evidence in favor of its use. In fact, the only thing that has level 1B evidence is the use of spinal cord stimulation, and now, due to the accurate study in 2017 by Dr. Deere, Dr. Levy, and others, we have dorsal root ganglion stimulation. I'll talk about that. So what is the literature support and the current therapy? So if you ask yourself, is CRPS a very common condition? Well, if you look at longitudinal studies conducted in large series of the population, you realize that the incidence is about 5.5 patients per 100,000. In the city of Chicago, where I practice, where there are 2.5 million people, that would be less than 150 new cases of CRPS a year. Well, I can assure you that there are some pain centers in Chicago that claim to see that many patients in several months. Forget about it in a single year. In fact, the National Organization of Rare Diseases has classified complex regional pain syndrome as a rare condition. What is the National Organization of Rare Diseases? It's a non-profit entity that looks at conditions worldwide that are not common. And in fact, CRPS in the entire world has been found to exist in less than 200,000 people. So despite what many of us may believe, that this is a common condition, in point of fact, it's a very uncommon condition. We know the history. Silas Weir Mitchell, who was an officer in the Union Army, described causalgia, and his description from more than 150 years ago still stands today. He gave a tremendous description. He talked about a special cause which provokes it. We don't know. We still don't know what causes CRPS. In fact, it's probably a confluence of many disparate insults to the nervous system. Burning pain, he talks about the fact that this occurs typically on the hand or the foot. In fact, if you see a patient, and I see this when I conduct independent exams, where the allegation is CRPS of the face, almost never occurs. CRPS of the torso, almost never occurs. CRPS of the shoulder or the thigh, almost never occurs. This is a peripheral distal condition. The patient is hyperesthetic, they guard the extremity, the face becomes anxious, they become hysterical. Again, his description going back to the American Civil War still holds true today. Anyone know who Wilder Penfield was? Wilder Penfield was a neurosurgeon practicing at McGill University with a great pedigree. He worked with Sir William Osler, he worked with William Cushing. And Penfield mapped the entire brain. He mapped the sensory and motor homunculus, and he's famous for that. This is now 85 years ago, and the reason why this is important is because if you look at his homunculus, his sensory homunculus, it almost correlates exactly to where we would find the greatest predilection for CRPS, the distal lower extremity and the distal upper extremity. So if you look now, we have a lot of nomenclature changes. In 1947, Evans from the United States coined the term reflex sympathetic dystrophy, but we know that the sympathetic nervous system is infrequently or uncommonly involved in these conditions, which is why there's no level 1 or level 2 evidence for the use of sympathetic blocks. In the latter quarter of the 20th century, in this very city in Orlando, Florida, a consensus group met in 1993 to once again change the nomenclature when we realized that the sympathetic nervous system was infrequently involved, and they coined the term complex regional pain syndrome. And we recognize that there are sensory changes, motor changes, pseudomotor changes, and vasomotor changes, which is why the Budapest clinical diagnostic criteria came into vogue somewhere around 2006 and 2007. Now, why was the Budapest created? Not to find more cases of CRPS, because the authors recognized that CRPS was overdiagnosed in many individuals. Now, why is it overdiagnosed? Because individuals don't construct a differential diagnosis. They see a patient with a red extremity, a patient who describes pain to touch, maybe there's some temperature variability in the extremity, and they automatically attribute that condition to CRPS without doing a differential diagnosis. And so there are a lot of ongoing issues with the diagnostic criteria. They are vague. We haven't defined yet what the temperature variability is between the affected limb and the non-affected limb. There's so much to be learned. We're really scratching the surface. Unlike other medical, like hypertension, where we can define a blood pressure in excess of 140 systolic over 90 diastolic, and we can label that as hypertension, or a patient with a hemoglobin A1C greater than, pick a number, 5.8, 5.9. We can say that that person qualifies as having diabetes. There are no objective tests to validate if someone has CRPS or not. So the new descriptor CRPS was also ambiguous, we know that. It led to patients being overtreated and erroneously treated with a lot of different things. Right here, surgeons saying that patient needs vitamin C to prevent CRPS. Well, there's zero evidence in favor of the use of vitamin C. There's zero evidence in favor of intravenous regional blocks. There's zero evidence in favor of tunneled catheters or epidural catheters, but people do them by consensus in the community. And of course, the Valencia consensus-based adaptation. This is a recent paper by Stephen Brule and by Norm Harden. They were two of the authors on the original Budapest diagnostic criteria, trying to, again, tighten the noose around what constitutes the condition versus what is factitious. So the European Federation, Pain Federation, this was by Chris Wells, who's a good friend of mine in Europe. They looked at Budapest and they tried to come up with 17 standards for the diagnosis and ultimately the management of CRPS. I'm just going to touch on them briefly. Standard number one is that when possible, we ought to be employing the Budapest diagnostic criteria. They're not infallible. There are still a lot of false positives that slip through the cracks when we have patients who present with this variety or this constellation of signs and clinical symptoms. But there is nothing that can prevent the condition from occurring. That's really an important construct. That's one of their standards. And also one of their standards is that there's no standard for not just controlling the condition, but eliminating the condition. Having said that, there's a whole host of factors unrelated to CRPS which can mimic CRPS. You know, in the 1930s and 1940s, syphilis was called the great mimicker because there was no treatment for it, and syphilis could mimic so many other medical conditions. John Bonica in 1962 said that RSD was the great mimicker of medical conditions because there were so many things that could look exactly like reflex sympathetic dystrophy, but were in fact other pathological conditions. Local pathology, disorganized or disordered vascular structures, connective tissue disorders, central lesions, peripheral nervous system disorders, malignancy, and of course factitious disorders. So if you see an individual who didn't have a trauma but they present as such, be skeptical. If you see an individual who has bilateral symptoms or signs alleged to be CRPS, be skeptical. If you see a person with a proximal representation, the shoulder, the thigh, where there's the allegation that this is CRPS, be skeptical. I reviewed the world literature for Stephen Waldman for one of his textbooks on CRPS of the face and the trunk. We found less than 15 to 20 cases worldwide in the history where there's actually CRPS of the face. It's extraordinarily rare. I'm going to go through 3 clinical vignettes right now. Here's an individual patient. She was a nurse. She was 53 years old. She fell in the parking lot outside one of her hospitals. She was undertreated by several individuals. I saw her 18 months after she had fallen. This is what I saw. She had obviously edema. She had color changes. She had a contracture of the right hand. And this is how she looked 10 years ago when I first saw her. And this is exactly how she looks today. She hasn't changed. So despite all the heroics that we provided for her, she refused a spinal cord stimulator. Again, spinal cord stimulation has level 1B evidence in its favor. Nothing else rises to the level of evidence as spinal cord stimulation. She refused it, and this is how she remains. Here's a fascinating case of so-called CRPS. Is it real or factitious? She was a 25-year-old female working as a certified nursing assistant. She slipped on a wet floor in the hospital, and she claimed to have injured her leg. Look at the left leg. Look at the perfectly symmetrical band around the knee, down the tibia. Well, she went to see Dr. Michael Stanton. And I can say this because he's retired now. When I used to give this lecture, I never mentioned his name. Stanton Hicks said that this was the worst case of CRPS he had seen in his entire career. She had lumbar sympathetic blocks, continuous lumbar epidural analgesia, medical management, physical therapy, and she refused to move her leg when I saw her for an independent exam. But I was skeptical as to this so-called changes around the knee and around the tibia. Well, guess what happened? They sent her for surveillance. A surveyor went to her home and actually filmed her running along her yard, pushing her kid in a stroller, totally unencumbered by pain. She was diagnosed as having a borderline personality. So with all respect to the great Stanton Hicks and others who misdiagnosed her, this was a scam, essentially. Here's another individual who I saw recently in my pain clinic. He was a 62-year-old attorney. He had been standing at a bus stop at the University of Chicago Law School when somebody gangbanged initiation rights, came up and shot him behind the leg. Now, he went to Thailand, created a very successful business, but this is what I saw him after 32 years after having had this gunshot injury. He came to me, you can see his right foot is red, you can see that there's atrophy of the gastrocnemius and other muscles, he had motor dysfunction, but he had no pain, and he had no tactile allodynia, he had nothing whatsoever to suggest he had CRPS. In point of fact, he came to me for cosmetic reasons to see if there was anything I could do to improve the muscularity of his leg. He did not, and does not have CRPS. And there's his foot right there for comparison. If you just saw this person, or if the person said, ouch, 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 that hurts me when you touch me, because really all you need is 2 out of 4 diagnostic criteria to qualify as having CRPS. Right now, if I'm standing at this podium and I say, I can't move my wrist, ouch, this hurts, I have CRPS by definition. I've met 2 out of 4 objective, so-called objective criteria. Yes, Deborah? That was from a peroneal nerve palsy that he had from the gunshot wound right behind where the sciatic nerve bifurcates 15 centimeters above the posterior crease of the knee. The bullet wound, which is a 22 gauge caliber, when he was a law student at U of C, penetrated his common peroneal nerve and left him with both a deep and superficial peroneal nerve palsy. Sorry. Screening and diagnostic tools, you should recognize that there are other criteria besides Budapest. There's development criteria, there's a criteria from Japan that we ought to be apprised of. Many of them are very interesting. Here's a great paper because it came from orthopedic surgeons. They don't typically study CRPS. You know, it's fascinating to me when orthopedic surgeons operate on patients. If the patients don't improve, what do? They send them to the pain clinic and they say, you have CRPS. Well, these orthopedic surgeons didn't say that. They looked at 100 consecutive patients coming for total knee arthroplasty surgery, and they found 0 cases of CRPS by strict adherence to the criteria, although there have been suggestions that CRPS can occur in up to 21% of individuals after major orthopedic reconstructive surgery. 0 cases of CRPS, and I really applaud them for undertaking this prospective analysis. Recognize that individuals with CRPS will have psychiatric disturbances. Up to 16% will be depressed. There are many psychiatric comorbidities. If you don't treat the comorbidities, you're not likely to help the individual. So what works, what doesn't work? Bisphosphonates and calcitonin may actually work. There's level 2 evidence in favor of bisphosphonates for early stages, calcitonin for late stages of CRPS. Dimethyl sulfoxide may work in cases for warm CRPS. N-acetylcysteine for cold CRPS. Steroids, no evidence in their favor. Anticonvulsants, very weak evidence in its favor. Antidepressants, very weak evidence in favor. Ketamine, very weak evidence in favor. How many folks in the audience are using ketamine infusions for CRPS? Many of us. No evidence really to support that practice. No high quality randomized controlled trials to suggest that this makes any sense. Cannabinoids do not work for CRPS. Sympathetic nerve blocks, we all do them. We do our stellate blocks, we do our lumbar sympathetic nerve blocks. No level 1, no level 2 evidence. In fact, only observational studies suggesting benefit. So why do we do it? We do it by consensus. But make no mistake, ladies and gentlemen, the insurance companies know this fact, that there is no evidence in favor of the performance of sympathetic blocks for managing the signs and symptoms of complex regional pain syndrome. Chemical and surgical sympathectomy doesn't work. Intravenous regional blocks do not work. Tunneled epidural catheters, tunneled brachial plexus catheters, no evidence whatsoever in favor of that. Amputation, terrible idea. Spinal cord stimulation, one of the best papers published 2017 by Tim Deere, Bob Levy, and Associates, called the Accurate Study. Looked at 152 patients randomized to get either dorsal root ganglion stimulation or conventional spinal cord stimulation. 81.5% of the patients with the Deere got much, much better versus about 55.7% of the patients with conventional stimulation. Conventional stimulation is still an option for clearly documented CRPS. Peripheral nerve stimulation, we just had a tremendous lecture on it. There's some evidence starting to accrue, but no level 1 or 2 evidence in favor of its use. TENS units seems to make sense. Cheap, inexpensive, non-invasive, but of course if the patient has allodynia, they're not going to use it. Non-invasive brain stimulation, no evidence in favor. Deep brain stimulation, lack of randomized controlled trials. Is this depressing to you all? Because you all thought what you were doing is based upon science. Well, what you're doing is not based upon science, ladies and gentlemen, except with the exception, possibly, of dorsal root ganglion stimulation. And this is a great paper by one of my great colleagues, Alan Kay, who's well known to us in ASIP, FSIP. Alan looked at all the world literature, found no benefit for vitamin C, ketamine, extremely weak evidence, physiotherapy, low quality studies, bisphosphonates may be effective. We don't use them nearly enough, nor calcitonin for that matter. Sympathectomy, extremely limited, as I've already told you. Spinal cord stimulation with some evidence. This is another great paper by Norm Harden and Steve Brule. Again, they were the architects of Budapest Diagnostic Clinical Criteria when they met in Budapest. And again, this was a consensus. This wasn't based necessarily on science, ladies and gentlemen, which is why when you use Budapest, even though it may be considered by some to be a reliable metric, the evidence behind it is not that significant or that strong. And so they found that there's mostly very low quality evidence for anything we do for CRPS. Does that depress you? Well, it is depressing. Here's one of my patients, a 31-year-old individual who fell in the workplace. You can see she has CRPS type 2 of the right lower extremity. Temperature changes, color changes, pain to touch, all the criteria met, motor disturbance. And I put in 3 DRG stimulators for her. You can see an L4, L5, and an S1. This was based on my interpretation of the Accurate Study published in 2017. Now we owe a debt of gratitude to Kemmler, who published longitudinal series of more than 50 patients who had either physiotherapy alone or physiotherapy with neuromodulation for CRPS. And he started publishing in the New England Journal of Medicine in the year 2000. So it's already 24 years ago, but he followed these patients out for up to 5 years. And he found that at 1 month, 3 months, 6 months, the patients who had the stimulator did better than the patients who had just the physiotherapy alone. And he found that the patients who were markedly or significantly improved was much greater than those who were unchanged by the use of spinal cord stimulation. And he found that the change in pain was about 2.5 on a numeric rating scale from 0 to 10, where 0 is no pain and 10 is the worst imaginable pain. And so this was a very intriguing and very thought-provoking series of articles by Kemmler. And this was up to 2 years. And he found up to 2 years that the patients who were markedly improved or significantly improved remained greater than those who were not improved. However, you can see that up to 5 years, and this is his follow-up in New England Journal of Medicine, 5 years after he started this process, that the change in pain was only 1 on a numeric scale. So what happened? How did we go from 2.5 to 1? Is it accommodation? Is it the fact that the stimulation lost its efficacy? That was his hypothesis. And so, however, patients were significantly happy with the results. You can see that 90% of the 20 patients with the implant indicated that they had positively responded, and 95% reported that they would undergo the treatment again for the same result. Here's one of my patients who got a nice tattoo. I said, "Why'd you get that tattoo?" She said, "My mom always told me if I was in a car accident, make sure I had clean underwear on at all times. And also to have this on my forearm in case that when they extracted me from the vehicle that the EMTs would know that I have a metal implant." Compact Initiative was created to look worldwide at data by physicians trying to gather information from patients with CRPS, very important initiative, published recently in Pain Medicine, basically realizing that a lot of patients with CRPS improve. I don't know if you do any injured workers type of stuff. I do a lot of it. Depositions, the lawyers for the plaintiff or the petitioner always say, well, the patient's got CRPS, they'll never improve. That's not true. Many patients go on. In fact, only about 15% of patients do not show marked or moderate improvement as time accrues. There are a lot of people who totally resolve CRPS. The lawyers don't believe that, but that is true. Cold limb may be a poor prognosticator. I'm sorry I'm a little bit over, Michelle, but I got started at about 4 minutes behind. Thank you. Monotherapy, probably not a good idea because this is probably a constellation of different conditions that have attacked the nervous system. Medication choice should also have a cost consideration built in. Treat multiple symptoms is better than treating a solitary symptom. And treatment outcomes should be discussed with the patient. There should be goals attached to what you do to the patient. You're not looking for a minimal change, you're looking for at least a 2-point change on a numeric pain rating scale. Here are some strategies for how to treat the patient. We don't have time to go through them all. We still use sympathetic blocks. Why? Because of consensus, not because of evidence. But you should understand, ladies and gentlemen, the insurance companies know that there is very weak evidence in favor of stellate blocks, lumbar sympathetic blocks. There's no evidence for intravenous regional blocks. There's no evidence for tunneled catheters, epidural or otherwise. And yet we do them by convention. Intravenous ketamine infusions, very, very weak evidence in favor of its use. The only level 1B evidence in CRPS is the use of spinal cord stimulation. I've already told you that. CRPS should have a multidisciplinary approach. I'll talk briefly about some of these blocks. The great Daniel C. Moore from Seattle, Washington, the Virginia Mason Medical Center, who was one of the great leaders in interventional pain throughout history. Danny Moore wrote 4 textbooks. He wrote Regional Block, Complications of Regional Anesthesia, Obstetrical Anesthesia, and Stellate Ganglion Block in 1954, the only book dedicated to this topic to date. And he wrote tremendous stuff. He talked about the use of blind techniques. Fluoroscopy may be used for your lumbar sympathetic blocks or stellate blocks. I prefer the use of ultrasonography because you can see these anatomical targets, muscular targets, vascular targets that you cannot see with the use of fluoroscopy. You can see the carotid artery, jugular vein, the longest colli muscle, which is one of the targets for the stellate block. Here's lumbar sympathetic block performed under the use of fluoroscopy. Sympathetic block is only used by convention. Again, the dorsal root ganglion stimulator is more effective, according to the accurate study of 2017, than is conventional neuromodulation. We talked about that. I'm going to skip through some of this. This is all in your slide deck. If you have an interest in learning about this, I encourage you to go back and pull the slides up. I'm going to finish now talking about 2 things. The cost burden. So the retrospective longitudinal study on the cost burden in 35,000 CRPS patients showed us that there is a 2.17-fold increase in total cost for patients with CRPS compared to normal cohorts without that condition. Prescription costs increased by 2.56-fold, and that the index year, the year of diagnosis, is when the costs are at the highest rate, accelerated rate for CRPS patients. Take that into consideration when you make your decisions about how to treat them. So the diagnosis year is what we have to contend with in terms of cost analysis when rendering decisions on what to offer our patients. And there's the cost ratio, 2.17. The final thing I'll mention, which is really important, and this is a new paper that came out in 2022 about gray matter volume. Remember I told you 85 years ago, Wilder Penfield mapped the entire brain's sensory and motor cortices, and he created the homunculus. Well, now it seems 85 years later that there's evidence from functional MRIs that document and corroborate Penfield's original work that show changes in the volume of gray matter in individuals with CRPS untreated, and as treatment accrues, what happens to that gray matter volume? It shrinks. So it proves Penfield's original hypotheses. And this is a beautiful paper. I encourage, if you have an interest, to go back and look at it. And it also shows a meta-regression analysis between the gray matter volume alteration in CRPS, as well as a gender variation, meaning the changes that occur in females versus males. So in conclusion, CRPS is purely a clinical diagnosis. There is no objectification for this condition. We don't have hemoglobin A1C or blood pressure to validate whether somebody really has this condition. You have a duty to your patients to create a differential diagnosis and eliminate or exclude competing and alternative conditions that can mimic this. This is the great mimicker of many other conditions, according to John Bonica, just as syphilis in the 30s and 40s was a great mimicker of many other medical conditions. Sympathetic nerve blocks are a mainstay, but there's no evidence in there. There's no hard evidence, no level 1 or 2 evidence in favor for their use. Spinal cord stimulation, level 1B evidence, is the only thing which arises to that level in favor of its use for CRPS. Early treatment determines success, and DRG is the up-and-coming modality. Sorry for going a little bit over. I thank you for your time and attention this morning.